Good morning. I'm Adam Mullan, one of the residents here. Welcome applicants to Temple. So I'm sure many of you have heard of deep gluteal syndrome. Probably not. So I initially set out to present the topic of Piriformis syndrome. Quickly realized that's really an outdated term, and this has really been only in the literature for about the past 5 years. So there's a couple, I want to say a couple, maybe like 5 to 6 articles just specifically focusing on the syndrome itself, but they reference a lot of articles regarding Piriformis syndrome. So just to give you guys like a little direction for the talk, deep gluteal syndrome is sciatica related to a non-discogenic source. Usually occurs in this space called the subgluteal space. So I hope you guys find this talk interesting. I hope you learn something from it. And maybe in 10 years, you know, when deep gluteal syndrome is this pervasive diagnosis, you'll remember me. So some of the objectives for the talk, I'm going to go over the anatomy of the subgluteal space. We're going to go over some of the deep gluteal syndrome components versus Piriformis syndrome and kind of compare the two. We'll talk about etiologies for deep gluteal syndrome. Also go over typical patient presentation. Go over some of the differential diagnoses that you should think about when a patient comes to you with gluteal pain, and also review therapeutic interventions, minimally invasive procedures, and just touch on some of the surgery as well. And then I will leave you with just a typical kind of plan of care and kind of outlook for the future. So the subgluteal space is bordered posteriorly by the gluteus maximus. Anteriorly is posterior acetabular column, the hip joint capsule, and the proximal femur. You can see over here the gluteus maximus on the image on the left, and then over here is the muscles are all taken off of the pelvis. You can see the proximal femur here with the acetabulum right here. So the lateral and medial borders are made up of the lateral lip of the linea aspera, which you can see running right along here in the gluteal tuberosity. So it's your femur on the right. And the medial border is this sacrospinous ligament, or the sacrotuberous ligament right here. So superiorly, the inferior margin of the greater sciatic notch marks off the superior border. Inferior border is marked off by the proximal origin, the hamstrings of the ischial tuberosity. So greater sciatic notch is pretty clearly marked, and then the ischial is right here. All right, I'm gonna have to turn my phone over because Ben's texting. So muscles within this space. Muscles within this space. So superiorly, it starts with the piriformis, superior gemellus, obturator internus, and inferior gemellus. Most inferiorly is the quadratus femoris. So these muscles all pretty much primarily act as external rotators at the hip joint. A little more on the sciatic notch, because this is actually an important anatomical landmark in a physical exam. The greater sciatic notch is this large notch in the pelvis just above the ischial spine. When they add the sacrospinous ligament, that'll actually convert the notch into a foramen, the greater sciatic foramen. And then the inferior border of the lesser sciatic foramen is set off by the sacrotuberous ligament. So this diagram, I just want to include this to show you some of the main muscles, the main nerves and joints in the deep gluteal space. So you can see marked SP is the sacral plexus. The piriformis is this large muscle here. And in just above the piriformis in the suprapiriform space, you'll see the superior gluteal nerve and artery. And just below the piriformis in the infrapiriform space, there's a number of vessels and arteries there. Most importantly, the sciatic nerve, the pudendal nerve, and then the inferior gluteal artery and nerve, along with nerves to the obturator internus, the gemelli, and the quadratus femoris. The lesser sciatic foramen really just contains the obturator internus. So I want to go over just some MRI images of the subgluteal space. What you can see, so this is an axial image here, axial slice, GM's gluteus maximus, and this is piriformis here at the P. We're just looking at the level of the piriformis. And the sciatic nerve, you can see with this white arrow. Forget that I can't point with the arrow here. This is the sciatic nerve right here. So this slice is a little bit more inferior. We're at the level now of the gemellus and the obturator internus complex marked with that OI. The sciatic nerve is again represented with an arrow. You have the posterior cutaneous nerve of the thigh, which is just medial to the sciatic nerve, marked with just the arrowhead. And then you can see the sacrospinous ligament marked right here. And then the ischial spine as well, just lateral to that. And then even more inferior, now at the level of the quadratus femoris, you can see the quadratus femoris is marked with QFM, ischial tuberosity, along with the hamstring tendon origin there, gluteus maximus, and then the sacrotuberous ligament, which runs right here. And the sciatic nerve marked with the arrow is, you can see a very large structure here. A couple more slices of MRI. This is a sagittal view. So on the left, this is a more medial, and then on the right is a more lateral view or slice. The piriformis muscle again, marked P, and then you have the obturator gemelli complex, the gluteus maximus here. This is you actually have a cross-section slice of the sciatic nerve. And over here, sciatic nerve running down, see the more long axis, quadratus femoris muscle here, glute maximus, medius, minimus, and then the obturator gemelli complex again. Okay, 2 more slices for MRI and we'll be done. So the one on the left is more anterior, and the image on the right is a more posterior slice if you are looking at a coronal view. So again, you can see sacral plexus up here, the SI joint, and then you have gluteus maximus over here, quadratus femoris, the arrow pointing to the sciatic nerve, and then over here you see SI joint. You can see more again the course of the sciatic nerve here, kind of coming down, along with the obturator internus and the hamstring origin here. So just a look at the sciatic nerve, kind of in a cadaver here. You can see it's marked number 1 here, enters the pelvis at that sciatic notch we discussed, just anterior to the piriformis, then passes anterior to the sacrotuberous ligament as well. Piriformis is marked number 2, and the sacrotuberous ligament is marked number 3. The nerve continues distally towards the ischium and the hamstring origin, which is marked number 4. And then passes posterior to the muscles of the gemelli obturator complex, marked number 5. And the quadratus femoris is the structure marked number 6, and it's been removed just a little bit there, just to kind of expose the lesser trochanter, that inferior portion there, marked number 7. So a little history on sciatica. So initially I was looking back and I could only find stuff in the 1900s, and then it actually turns out that Hippocrates may have been the first guy or physician to use the term. He was thinking the source of this pain was actually from the arthritis of the hip and not actually from a nerve. Actually wasn't until the 1700s this physician in Naples, Dr. Cotugno, proposed that maybe sciatica actually comes from the nerve itself. It's used to describe any kind of pain that radiates down the leg and the distribution of the sciatic nerve. While there's some research going on about sciatica and its origin, some physicians propose that possibly maybe there's some component of the piriformis muscle entrapping the nerve and causing this pain. But around that same time that they were publishing their work and doing research for an extrapelvic source of sciatica, the authors Mixter and Barr in 1934 published a study on the effects of disc herniation and its role in radicular pain. And that actually started the era of the disc, where most providers now believe that sciatic pain is a result of herniation at the nerve roots on the lumbosacral spine. So sometimes with medicine and other things, we need to go back and reevaluate our thinking. And I think we're seeing now with new imaging strategies, including endoscopy and MR neurography, that there are potential other causes of sciatica type pain, which we'll get into, specifically deep gluteal syndrome. The sciatic nerve, did I skip a slide? All right, so the sciatic nerve, it has, it's a very mobile nerve. It actually, with movement, can move about 2.8 centimeters. And this occurs during hip flexion. And it's all dependent on knee flexion as well. If the knee's extended, the sciatic nerve is putting more stress than if the knee is flexed. So this slide is actually video, endoscopic view of the sciatic nerve, showing some of that movement. So you can see the sciatic nerve here. He's actually moving the patient's hip and flexion right now. You can see that it actually migrated medially, pretty fair distance. You have to take my word for it that it's 28 millimeters. A brief review of the piriformis syndrome. We kind of talked about that already, but piriformis muscle passes through the greater sciatic foramen, originates in the ventrolateral aspect of the sacrum, inserts in the medial aspect of the greater trochanter. So deep gluteal syndrome is more of a preferred term. It describes the buttock pain caused by this non-discogenic source, extrapelvic entrapment of the sciatic nerve, or also entrapment of the pudendal nerve in the subgluteal space. It's felt that this is more of an inclusive term than piriformis syndrome and more appropriate for further research. It's the result of those advances like endoscopy and MR neurography that are giving us a better understanding and the need for this more inclusive term of for posterior buttock pain. So these are some proposed etiologies of deep gluteal syndrome that we're going to review. There's really a limited amount of research on these, so I'm just going to kind of touch on the major points. So first, fibrous bands. They're subdivided based on their pathogenic mechanism. The type 1 bands are compressive. They compress either the nerve from an anterior to posterior or posterior to anterior action. And the bands usually extend from either the border of the greater trochanter to insert on the gluteus maximus, and onto the sciatic nerve, or up and through the sciatic notch. Type 2 bands, they bind more strongly to the sciatic nerve itself. They anchor the nerve into a single direction, hence the name the horse strap band. And what they do is they prevent excursion of the nerve with hip movement. And they can attach to the sciatic nerve laterally from the greater trochanter, or they can attach medially from the sacrospinous ligament. Lateral bands are actually more common. And then type 3 bands are more erratic distribution. They can anchor the nerve in multiple directions, actually. It's kind of the catch-all type. And the classification of these is more appropriate for a surgeon to understand. It helps them with the operative preparation, get ready for the tools that they're going to use, and also positioning for the patient during the surgery. I don't see any utilization for physiatrists yet. I don't know if maybe a Graston technique or something might be something they could employ later on. So these are just some cartoon drawings of the different bands in images A and B. Those are examples of the type 1 bands, either going anterior to the nerve or posterior to the nerve. And then C and D are the type 2 fibrous bands, where you can see attaching to either the greater trochanter over here, or the sacrospinous ligament. So this is another video of a compressive bridge type band. It is posterior to anterior entrapment of the sciatic nerve, and the surgeon's kind of dissecting out the band. I guess he already cut it, and now you can see the sciatic nerve under here. Unfortunately, after he decompresses it, he didn't move the hip to show that the nerve is actually free. So one of the etiologies of deep gluteal syndrome could also be piriformis syndrome. There's 2 different types of piriformis syndrome. There's a primary and a secondary type. Primary piriformis syndrome is usually related to an anatomic anomaly. So it's accountable for less than 15% of the types of piriformis syndrome, though. So just to review quickly, it could be from an anomalous course of the sciatic nerve, or it could be from an anomaly in the piriformis muscle itself. There's 6 different anatomic variations. Just because a patient has the anomaly doesn't mean they're going to have, deep gluteal syndrome or sciatic nerve entrapment. Just to review, in image A, that's the normal. You have like 83% of patients have that type of nerve passing, sciatic nerve just passing in the infrapiriform space. There was a study by Small in 2010 where they dissected 6,000 cadavers, and basically from those numbers, we're able to kind of say that, extrapolate and say 83% of population may have this type of anatomical setup. In figure B, you can see the sciatic nerve is divided, and part of the sciatic nerve actually pierces through the piriformis muscle itself. This is seen in about 13% of the population. The rest are more rare, and in the interest of time, I'm going to actually skip through these slides. So When I talked about the anomalous attachments to the piriformis muscle itself, and the thought is basically if the piriformis muscle itself is either wider at its origin or it inserts on a different site than it should, that these variations can cause disturbance in the normal alignment of the axis of contraction and precipitate a deep gluteal syndrome or related to piriformis syndrome. So the secondary causes of piriformis syndrome, the first cause we're going to talk about is hypertrophy of the piriformis muscle itself. Now, some patients will have hypertrophy of the piriformis muscle, but they won't actually have any symptoms. So the specificity and sensitivity are actually pretty low if you find on imaging a patient with just isolated hypertrophy of the piriformis muscle. When you see hypertrophy of the piriformis muscle and you see a hyperintensity of the sciatic nerve associated with it, the specificity for piriformis syndrome actually increases to about 93%. So usually treatment for a patient is conservative at first. You do rest, NSAIDs, muscle relaxants, try a 6-week course of therapy. If in refractory cases, you could trial something like Botox, or eventually, if it doesn't heal, even an endoscopic piriformis resection. And we'll get into more of that later on in the talk. So here is an MRI. You see on the right, the piriformis muscle here versus the large piriformis muscle on the left here. And then this is the sciatic nerve, and you can see the hyperintensity of the sciatic nerve here by the piriformis, which would be indicative of secondary piriformis syndrome. Another cause of secondary piriformis syndrome is dynamic entrapment of the sciatic nerve by the piriformis muscle. This is not uncommon. Usually the symptoms are more transient, and the imaging may or may not show nerve signal hyperintensity. The definitive diagnosis in this case, according to Dr. Martin, is basically an endoscopic evaluation demonstrating entrapment of the sciatic nerve with hip movement. Sometimes you can trial a test called the infiltration test, where you inject a large amount of injectate into the peristaltic space to kind of break free and see if that improves the patient's symptoms that are of the transient piriformis syndrome. So this image is an MRI just showing basically the entrapment of the sciatic nerve near the piriformis muscle, but there's no abnormalities in the piriformis muscle itself. There's just this hyperintensity of the sciatic nerve. And then on the right, it's just an endoscopic image of the piriformis muscle after it's been resected. You see some of the tendon in the muscle belly at the 2 arrowheads, and then just at the arrow itself, you see the sciatic nerve. Another secondary cause of piriformis syndrome is fibrosis of a previous piriformis release. It's actually pretty common after piriformis release to see the piriformis muscle retracted, and then you get the impingement of the sciatic nerve at that muscle belly. Usually that infiltration technique where they inject that large amount of injectate doesn't work quite as well to help patients with this, and the surgery is really the biggest option. So a couple more secondary causes of piriformis syndrome are trauma and overuse injuries. With overuse injuries, you can see avulsions, tendinosis, strains, calcifying tendinosis, and spasm. It should be noted that the piriformis spasm itself is a diagnosis of exclusion. You want to look and see if they have that dynamic entrapment of the sciatic nerve first. Although each case, usually you trial conservative therapies and then progress through the minimally invasive therapies and, if necessary, surgery. But workup in cases of trauma, you may want to consider an MRI to further evaluate for sites of entrapment, including inflammation and also formation of those fibrous bands and the other things we just discussed. So a more rare cause of deep gluteal syndrome or etiology of deep gluteal syndrome is obturator internus gemelli syndrome. It's kind of theoretical, but as the sciatic nerve passes anterior to the piriformis and posterior to the obturator and superior gemellus complex, there's like a thought that they could have a scissor-like effect on the nerve itself and cause irritation, inflammation with sciatica type syndrome. Quadratus femoris pathology, like a swollen quadratus femoris or inflamed quadratus femoris can impact the sciatic nerve as well and cause irritation. There may be a tear at the distal myotendinous junction, which can precipitate that edema, the swelling, and result in that inflammation of the sciatic nerve. The ischiofemoral pathology. So the normal ischiofemoral space is about 23 millimeters. When it gets down to about 13 millimeters, that's when you start to see entrapment of the sciatic nerve. It's also related to swelling of the quadratus femoris and also subsequent sciatic nerve irritation. Imaging will show either atrophy or edema in the quadratus femoris. Hamstring pathology. So the hamstring origin at the ischial spine you can have enthesopathies there, and there's a list of the different types of enthesopathies. I'm not going to read them to you, but the pathology is related to the edema and also sciatic nerve irritation again on imaging. And chronic inflammation can theoretically lead to adhesions of the sciatic nerve and also in the structures between the hamstring origin as well. And that will result in traction and entrapment with hip motion and deep gluteal syndrome. Two more causes of deep gluteal syndrome include gluteal disorders. There's really not much on this, but I guess children with gluteal contracture, congenitally, who have had a lot of intramuscular injections to the gluteus muscle over time can develop entrapment of the sciatic nerve and may present later on in life. So it may be an important history to take from them. And then orthopedic causes, there's a thought that the changes in the alignment of the femur and the pelvis could possibly precipitate a patient to have sciatic nerve entrapment and develop deep gluteal syndrome. Pudendal nerve entrapment. So this was interesting because most of the stuff that I've been reading is related to the sciatic nerve entrapment. And there's one paper where the authors actually talked about pudendal nerve entrapment, and I actually reached out to them and they responded, which was surprising. And they basically said pudendal nerve passes into the subgluteal space, and therefore its entrapment could also lead to symptoms. So if they have genital symptoms, pain in the pudendal nerve distribution, they might also have tenderness medial to the ischial tuberosity as well. That could be a sign of pudendal nerve entrapment in the subgluteal space. So the pudendal nerve, remember, passes posterior to that sacrotuberous ligament and also through the subgluteal space just below the piriformis muscle. That being said, pudendal nerve entrapment outside the subgluteal space is not an etiology of deep gluteal syndrome. It would just be pudendal nerve entrapment of another variation. So I wanted to talk about the clinical approach to a patient that comes to your office with deep gluteal syndrome. Usually these patients are going to come to you, they're going to have more than likely months to years of pain. They'll have probably had the workup for lumbosacral spine disorders, looking for disc herniations. They may have even had a lumbar spine surgery. If they haven't had that, you definitely want to rule out the most common causes for back pain and posterior hip pain. You may want to start with that X-ray, start with some therapy, do MRI. You want to rule out any kind of intrapelvic entrapment, any gynecologic causes. Is this a cyclic cause? Could it be related to an endometrioma? You also want to make sure that there's no urologic causes for their pain. And then you can consider deep gluteal syndrome. So high resolution imaging at the pelvis and the gluteal region can help further diagnose the deep gluteal syndrome. One other thing you want to consider is patients have been in pain for months to years possibly. Are they on high dose opiates? Is their social function limited as a result of their pain? Are they not working? Are they not doing the things they like anymore? You may want to refer them for psychological evaluation as well while you're doing your workup, just to ensure that your outcomes are going to be good, because otherwise they might not get better even if you're doing the right thing for them. So typical history, they may have a history of trauma. They could either have pain with sitting or walking, depending on the etiology for their deep gluteal syndrome. The radicular pain or paresthesias will usually be unilateral, but sometimes they could have bilateral pain. Reflexes may or may not be decreased in the Achilles tendon. You may have motor weakness as well, and it may mimic some sort of like intra-articular hip pathology or a hamstring tear. On the right here, you see this typical antalgic posturing where the patient is preferentially putting weight on their healthy ischium. The pain that they're going to complain of is that sciatica type pain running down the leg. They'll have possible tenderness in the gluteal region and also retrotrochanteric region as well. The diagnosis for deep gluteal syndrome, though, is not based on one single symptom. There's no pathognomonic symptom. It's usually a set of symptoms that will kind of lead you to it. Just to emphasize why the history is important. In sitting pain, that's more entrapment beneath the 30 minutes or longer. Patients that complain of walking pain, that's more consistent with ischiofemoral impingement, and palpation lateral to the ischium will actually cause them pain as well. So there's a number of physical exam maneuvers I want to go over. First, Dr. Martin out of Baylor University is an orthopedic surgeon who has published a lot of the literature on this so far, recommends a 5-level examination assessing the osseous structures, capsulolabral, musculotendinous, neuromuscular, and then finally the kinetic chain. So we all know this test, the straight leg raise. If it's positive, it's considered La Saiget's sign, some French physician. So basically, the knee is fully extended. The examiner passively brings the hip into flexion. Now, for intervertebral disc herniation between 30 to 70 degrees, if you have onset of pain, that's greater than 90% sensitive for intervertebral disc herniation. Now, Dr. Martin and his colleagues published a study looking to see what the accuracy of this test is in the diagnosis of sciatic nerve entrapment. So there's a small study. It was only about 33 participants. 23 of them actually had confirmed sciatic nerve entrapment on endoscopic evaluation. So of those 23 patients with the confirmed sciatic nerve entrapment, only 4 of them had a positive straight leg raise. So it may not be the best test to diagnose sciatic nerve entrapment. But fear not, there's other physical exam maneuvers we can do. So the seated piriformis stretch test. So basically, while palpating just about 1 centimeter lateral to the ischium with the middle finger and proximal to the sciatic notch with the index finger, the examiner takes the flexed leg, hip, it's flexed at 90 degrees of the hip, fully extended at the knee, and internally rotates the leg. This is all passive. If that recreates the patient's pain, that would be considered a positive test. And what we're doing is we're stretching the piriformis muscle. We're narrowing that space in the infrapiriform space between the inferior border of the piriformis and the superior gemellus. So out of those 23 patients with the sciatic nerve entrapment, 12 of them had a positive seated piriformis stretch test. This is just another variation of the exam. You can do it with a patient lying supine. This was taken from another surgeon, Dr. Bird. So the patient's lying supine, hips extended, examiner is passively internally rotating the limb at the hip. If this test is positive in this position, it's called the Freeburg sign. And now I got this from Mullan. They just call this the piriformis test. It's another passive stretch of the piriformis muscle. Patient's lying in the lateral decubitus position at the edge of the table. The symptomatic hip is flexed about 60 degrees and the knee's at 90. And the examiner is passively adducting the hip past the midline, applying force on that lateral aspect of the knee. Again, we're stretching that piriformis, and if it's tight and inflamed, the sciatic nerve is involved as well. Then you'll have complaints of pain at the site of the piriformis, but also radiation of that pain down the leg and a sciatic distribution. The active piriformis test is a resisted test. So it's the patient's again in the lateral decubitus position, good legs on the table. Symptomatic hip is flexed to 60, knee is at 90, and the patient's asked to externally rotate and abduct the hip against resistance applied at the knee. The examiner is again palpating in those same 2 landmarks we discussed earlier. And pain in the region of the piriformis or pain in the sciatic distribution is considered a positive test. So 18 of the 23 patients that had endoscopic confirmed sciatic nerve entrapment had a positive active piriformis test. This is just another view of the same test. I don't know if they should call it the Hollywood beach pose, but in hip flexion, the piriformis actually also becomes a weak abductor as well. So that's why they're having you externally rotate and also abduct the hip. This is another variant of the active piriformis test where the patient's lying supine, and you can provide resistance, lateral aspect of the foot here. So Dr. Martin and his colleagues noted that the combination of both the seated piriformis stretch test and the active piriformis test increases the sensitivity of the test up to 91% and specificity to 80% for an endoscopic finding on sciatic nerve entrapment. That's only on an N of 23, but this could be more studies to be done. So for ischial femoral impingement, the test, you would have the patient lie in the lateral decubitus position. You would take the patient's affected limb, which is on top here. You're going to extend the leg at the hip, and with 0 degrees of abduction and adduction. And that should recreate the patient's pain. That would be a positive test. Now, if you abduct the hip and repeat the test and bring back the leg in extension, and the pain is not present anymore, that would also further validate the findings of ischiofemoral impingement, because you're opening up that space. This is just an image to kind of show that there really is a room here between the ischium. So ischial tunnel syndrome is also known as hamstring syndrome. This has to do with those enthesopathies we talked about. The pain can be increased. The patient is when they're flexing their hip and extending the knee and putting that the hamstring at stressed. That might increase their pain. They may be limping when they come into your office. So the test for this, they call it the active hamstring test. You have the patient seated on the table. They test for knee flexion strength at 90 degrees. That should show that their pain is not present. It should also show that the strength is 5 out of 5. Now, when you have the patient extend their knee about 30 degrees and test for knee flexion strength, you're going to have complaints of pain. And you're also going to probably find weakness as well in the patient. That would be considered a positive test. Again, you're palpating with the ischium and the sciatic notch as well. And if you palpate lateral to the ischium, that further points towards an ischiofemoral, an ischial tunnel or a hamstring syndrome. So a little bit about the palpation of the structures in the gluteus region. So at the sciatic notch, if there's tenderness there, that would be consistent with a piriformis syndrome and sciatic nerve entrapment. Just lateral to the ischium would be more consistent with either ischial tunnel syndrome or ischiofemoral impingement. And we know the exam maneuvers that you can do to flesh out the cause there. And then just medial to the ischium, palpation can elicit pain that would be consistent with more of a pudendal nerve entrapment. Your history should really kind of point you towards that with pudendal nerve pain or pudendal nerve distribution pain. This is just, again, to kind of hammer home the point of the palpation, but you can see this red here is the piriformis muscle. This is sciatic nerve. He's palpating at the greater sciatic notch, pushing on the piriformis and on the sciatic nerve. Over here, you see the hamstring tendon here. He's just lateral to the ischium. This is the sciatic nerve. Pain here will be consistent with compression of the sciatic nerve, either from ischial tunnel syndrome or ischiofemoral impingement. Femurs actually flex out of the way here. And then finally, this is the sacrotuberous ligament and the pudendal nerve here, and he's palpating medial to the pudendal nerve, or medial to the ischium and at the pudendal nerve, which would be more consistent with a pudendal nerve entrapment. This kind of just summarizes everything we just went over. So let's talk about some imaging modalities that you can use for the patients that come into your office with deep gluteal syndrome. Ultrasound is heavily used in physiatry and radiology as well. And Dr. Kara published in 2012 a study evaluating the applicability of ultrasound in cases of sciatica. Previous studies, they had found enlargement, either distal or proximal to a site of entrapment on ultrasound, and they thought that it's possible we might see increased cross-sectional area compared to normals in patients that have sciatic nerve entrapment on ultrasound. So the parameters of this study, they looked at sciatic nerve measurements and the pain and also the symptom duration, and compared that to the measurements of the sciatic nerve. So they took about 30 patients. There were 10 men, 20 women with low back pain and unilateral sciatica. The history and physical, they did a very thorough one. They did a neurologic exam on everybody. Everybody got a nerve conduction study in EMG, and everybody had an MRI of the L spine if they hadn't had one done in the previous 6 months. Their pain was evaluated on the visual analog scale, and patients with any kind of disease like diabetic neuropathy or any peripheral neuropathy were excluded from the study. The physiatrist performing the ultrasound was experienced in musculoskeletal ultrasound. They used a linear array probe. They looked at both the unaffected and affected sciatic nerves. They started out at the subgluteal fold, and then went distally along the course of the sciatic nerve and took 2 measurements. They measured at the mid-thigh, and they measured just proximal to the bifurcation of the sciatic nerve. And that's where they looked at the cross-sectional area, and they looked at the diameter of the sciatic nerve. So this is one image of an ultrasound of a patient. The image on the left is actually the right leg. The image on the right is the left leg. You can see enlargement of the sciatic nerve compared to the normal or unaffected leg on the right. So the results, they noted that ultrasound measurements were significantly larger on the affected side compared to the unaffected limb. Swelling ratio at the mid-thigh, but not at the bifurcation, negatively correlated with symptom duration, but swelling at either level did not correlate with VAS score. So if their pain was really high, it didn't mean that their sciatic nerve was more swollen. The results were pretty much expected. They know the animal studies with compression neuropathy resulted in either thinning of the nerve at the site of compression with either proximal or distal enlargement, and they wanted to confirm that. We've also seen an ulnar nerve entrapment and cubital tunnel syndrome, swelling of the nerve either proximal or distal to that site of entrapment. A word of caution, though, that the authors, they didn't really go into this, but they did mention that patients with nerve impingement of disc origin also had swelling of the sciatic nerve. So you want to make sure, it's not necessarily entrapment of the sciatic nerve peripherally, but it could also be more proximal compression as well. So the interventions that ultrasound can be used for, in the Journal of Ultrasound Medicine in 2015, Dr. Rosales published a pretty complete review of ultrasound-guided infiltration technique around the perisciatic space. And their objective was to really reach these inflamed areas and break up the tissue and free the sciatic nerve from any entrapment. They compared their results to what's considered kind of the gold standard endoscopic release of the sciatic nerve. The procedures were performed by a musculoskeletal trained radiologist in this case. So they had 49 patients, 28 men, 21 women, mean age of 40 years. This is a retrospective case series, patients with diagnosis of deep gluteal syndrome. They didn't have a control group. And they looked at duration of symptoms. They looked at the pre-procedure and post-procedure visual analog scale scores. They looked at the duration of the effects of the infiltration, like how long did their pain relief last. And they also looked to see if there are any subsequent medical events or adverse outcomes. A little bit more about the solution that they used. They used a total volume of 25 mLs of infiltrating solution. As an ml of corticosteroid, 4 mLs of a local anesthetic, and then 20 mLs of saline. And it's thought that this high volume is going to help create enough pressure and kind of break up those fibrous bands and adhesions that have occurred around the sciatic nerve. This is just an image of the technique they use. They're completely aseptic. The patients were in a prone position. They would start with an ultrasound probe locating the sciatic nerve between the long head of the biceps femoris and the semimembranosus muscle. And the nerve was followed proximally to this subgluteal space, basically the plane between the gluteus maximus and they call them the pelvitrochanteric muscles, which are really your gemelli, your obturator, and your quadratus femoris muscles. The infiltration, they used a spinal trocar needle. They inserted it at a 45-degree angle longitudinally, and then they went from a 5-degree angle laterally to medially, and they followed the needle tip till it was just medial to the sciatic nerve, and also in that subgluteal space, and then injected. So you can see this is kind of a long axis view of this this is a cross-sectional view of the sciatic nerve, and that's supposed to represent that like aponeurotic space between the gluteus maximus and the pelvitrochanteric muscles. I forget that the arrow's not working. So this is the space they're aiming for in the sciatic nerve, and then after infiltration, here's the sciatic nerve, and you can see a lot of the infiltrated solution around the sciatic nerve itself in that hypoechoic region. So the results, they had no adverse events. The procedure took about 30 minutes. About 73% of patients had pain relief, and their scores could improve from about 8.3 on average to 2.8 on average post-procedure. The average duration of pain relief is only about 5.3 weeks. And 50% of patients had no recurrence of pain after 2 years. The other 50% did have recurrence of their pain after 5.3 weeks or sooner. That was just an average. But you got to remember, otherwise these patients were refractory to most treatments. So providing them pain for even 5 weeks is some of them, half of them up to 2 years is pretty remarkable. So then they compared the results to the endoscopic outcomes in sciatic nerve entrapment. In endoscopy, pre and post VAS scores were pretty similar actually. Pre-procedure and endoscopic release of the sciatic nerve was usually 6.9, and then post-procedure improved to 2.4 versus 8.3 and 2.8. The big difference, though, pain relief was achieved in 83% of patients that underwent an endoscopic sciatic nerve release at 12 months versus our 5.3 weeks. The authors do feel, though, that ultrasound is a less expensive, less invasive modality. It's faster, it's safer, and it's definitely worthwhile to trial in the patient with sciatic nerve entrapment. And at the very least, it could be diagnostic and may help as a indicator of the success of a sciatic nerve release in endoscopy. So they do these under CT guided injections, and they also do them under MRI guidance. This is just a video showing the infiltrate. See the roots of the sciatic nerve going into that peristatic space. Here's the sciatic nerve here. You can see all the infiltrated solution in that space we were talking about. It's kind of a more 3D kind of picture. So MR neurography is a relatively new type of magnetic resonance imaging. From what I can tell, it came out sometime in the early 90s, and it's MRI that specifically is able to look at the nerves and assess the health of the nerves based on some sort of molecular makeup of the nerves and the water in them. So Dr. Filler at Cedars-Sinai Medical Center looked at 239 patients with sciatica who standard diagnosis and treatment didn't help. And after doing MR neurography on all of these patients, they came up with this list of new diagnoses for the patient that were not previously noted. Piriformis syndrome was the number one with about 67%, followed by a distal foraminal entrapment just outside the neuroforamina. Also, ischial tunnel entrapment was 4.7%. 4.2% still had no diagnosis after the MR neurography. And you guys can kind of read the list yourselves, but sacral fracture is down there at 0.4%. So this is an image, MR neurography. You can see the piriformis muscle on the left is hypertrophy compared to the right. And then in this image, you're looking at the sciatic nerves. You can see the sciatic nerve here versus the sciatic nerve here. There's a hyperintensity of that sciatic nerve. So we have a hypertrophy piriformis muscle along with a hyperintense sciatic nerve, which could be indicative of a secondary piriformis syndrome related to hypertrophy. And then this is another axial slice of the pelvis here. And these arrows are looking just again at the sciatic nerve, that's a healthy nerve, versus a hyperintense sciatic nerve. And then this is they call it a curve reformatted neurography. And you're actually looking at the sciatic nerve that comes through the pelvis. You can see there's a change in the intensity here, as well as there's, believe it or not, change in the fascicular pattern of the nerve. It was interesting, Dr. Filler's study, there's a patient that came in with a newly diagnosed CRPS, and they went on MRI and noted that there's entrapment of the sciatic nerve at a previous site of fracture in the pelvis. So after MR neurography, they went in endoscopically, released the sciatic nerve, and the CRPS was actually cured. I didn't think I've heard of anybody curing CRPS, so it could be offering a new treatment modality for those patients as well, or at least help us kind of look into the etiology of their CRPS. So a little bit about the therapeutic interventions. Pharmacologic interventions include nonsteroidals, Tylenol, and muscle relaxants. Usually nonsteroidals are kind of your first line. If they have gastritis or some other reason they can't take them, you could try Tylenol. Muscle relaxants, depending on the level of pain that they're having, you could try them. I would also consider their age and what other medications they're on. You don't want to oversedate them. Modalities always work well. Heat and ice, usually pre or post therapy, will help with some of the pain. Ultrasound and laser are recommended. There's not really any evidence behind their use. And then a physical therapy course ranging from about 6 to 12 weeks, focusing on stretching and range of motion, the muscles around the hip, and then strengthening the core muscles and also strengthening of the abductors and adductors at the hip will help or is thought to help with patients with deep gluteal syndrome. Massage following therapy may help to provide some pain relief and make the patient feel better. Then activity modification, you want to rest in the acute phase or limit the movements that are causing the pain. Some of the minimally invasive treatment options are the corticosteroids and botulinum toxin injection. They can be either ultrasound guided, they could be guided by CT or MRI. So, you know, we discussed a little bit about, you know, the ups and downs of ultrasound guided injections. The radiologists feel that it doesn't show the muscles and the nerves as well. There's a lot of neurovascular bundles that are present in the subgluteal region. There's a risk for bleeding with injection. So they recommend MRI because you can better visualize and then also add contrast to the injectate and see, you know, where you've actually injected your solution. Although we saw on ultrasound that you can visualize your injectate as well around the sciatic nerve after you infiltrate the peristatic space. When you're doing a piriformis muscle injection, though, and you want to be sure that that Botox is just in the piriformis muscle and not bathing the sciatic nerve, it may be better move to try an MRI-guided injection and have the radiologist perform it. There was a study done, though, where they looked at the use of ultrasound for a piriformis muscle injection. I think this guy was Dr. Smith. He basically took a number of experienced musculoskeletal ultrasound providers in physiatry that had never done piriformis muscle injections under ultrasound before and taught them in one day how to inject the piriformis muscle. And what they used was this saline solution with some blue latex in it. They were in a cadaver lab, injected under piriformis guidance into the piriformis muscle, and then dissected out and noted that the blue latex solution was only in the piriformis muscle. Then they applied that clinically under fluoroscopy along with ultrasound guidance. They injected into the piriformis muscle with a little bit of contrast and then confirmed the placement after ultrasound guided injection with a fluoroscopy, and they saw that the injectate was in the distribution of the piriformis muscle only. You know, CT guided injections can be reserved for patients that absolutely need it, but we try to not do that because of the amount of radiation to the pelvis. It's up to like 500 x-rays, or chest x-rays, basically the equivalent of 500 chest x-rays in radiation. And then in terms of Botox use versus corticosteroid use, if you're looking to help with piriformis syndrome and a hypertonic muscle, Botox has been shown. There's a Cochrane review that showed Botox has better outcomes than corticosteroid injection in the piriformis muscle. All right, so the surgery, I wanted to just kind of briefly touch on surgery because it is a pretty important topic in this talk. So this is just the setup for a normal endoscopic surgery. They're looking at bony landmarks, and then that's where they put their ports. This is an endoscopic view of the sciatic nerve. On the left, you see the healthy sciatic nerve with vascularization. On the right, you see what they call a shoestring appearance. You don't see the vascular appearance there, and there's no like epidural fat around the nerve. So for surgery, you could do it endoscopically or you could do it open. And endoscopic allows for a complete evaluation of that sciatic nerve along its course versus the open procedure, which previously was done. They would actually reflect the gluteus maximus, and they'd have to visualize it that way. Now they're doing a transgluteal approach where they just make a small 3-centimeter incision and they'll bluntly dissect through the gluteus maximus to get to the piriformis and the sciatic nerve. But the visualization along that course of the sciatic nerve is limited. Much more limited compared to endoscopy, where you can probe through different muscles and different layers. The authors felt that the lateral technique in endoscopy, where patients lying on their side, allows for concomitant manipulation of the hip during surgery. So, you know, the whole purpose of the surgery is to release the sciatic nerve, and how do you confirm that you've released it? You got to move the leg. So after they complete release the sciatic nerve, they'll basically flex the hip, internally rotate, externally rotate, and confirm release of that sciatic nerve. They'll use nerve conduction and EMG in the operating room to confirm that they're where they need to be and they're not around any other nerves, and limit the poor outcomes. Sometimes repeat surgery may be necessary as well. So post-operatively, so you usually have a 24-week course of therapy after surgery. begins usually with just passive range of motion at the hip, and then you can progress to nerve glides, and then finally do piriformis stretching. One author recommends wearing of a knee brace during the early stages of physical therapy with liberalization as the weeks progress to prevent that strain on the sciatic nerve. With the knee extended, remember, you're putting more strain with hip flexion on the sciatic nerve. So he actually recommended the knees locked at 45 degrees during therapy for the first 3 weeks, and then you can progressively liberate by 10 degrees week by week after that. So these are just some examples. On the left, you see circumduction of the hip and mobilization of the hip. On the right, you see the patient performing a piriformis stretch in the seated position. They're just crossing their leg, bringing the knee towards the contralateral shoulder. And then I won't go into too much nerve glides. We can probably talk about that for an hour. But patients in the seated position here, you see their necks extended, their knees flexed, and their ankles dorsiflexed. And then they flex their neck, extend the knee, and counterflex the ankle. This is thought to help with the nerve movement and prevention of entrapment. So I hope this was an interesting talk. I think that there's a lot that we don't know in medicine, and it's always humbling when we find that the thoughts of a physician from the early 1900s may have been spot on, and we just kind of got off track, and now we're going back and evaluating that we have the technology and the imaging ability. If a patient comes to you with pain, just take their pain complaints seriously and try to help them best you can, because they may have had lumbar spine surgery, but they shouldn't be sentenced to a life of chronic low back pain and radicular pain if there is a possible solution. So just remember this, and remember that just like the nerves can be entrapped in the carpal tunnel or cubital tunnel, we could also have entrapment in other areas, such as the deep gluteal space. So I want to thank Dr. Weineck for being my advisor for this. And thanks to Ben for not only bringing in breakfast, but also helping us when we were down a couple chiefs for driving in the applicants today. And good luck to the applicants. It's a very relaxed day. The interviews are going to be great. And then you guys get to look forward to going home, hopefully, if you're not working tomorrow, and eating a big meal. So happy Thanksgiving.